Okay, welcome back to the Action Collaborative's virtual symposium. Our next and final session of the day will focus on building a health system that is equipped to prevent, treat, and manage opioid use disorder. Currently, our healthcare system is not sufficiently designed to address and promote the holistic needs of individuals with opioid and other substance use disorders. So I'm delighted to introduce this panel of experts who will discuss how to build the needed capacity, competencies, quality of care, payment structures, and incentives to ensure effective, quality, and affordable healthcare for individuals with opioid and other substance use disorders. This session will be moderated by Dr. Andrey Ostrovsky, who is Managing Partner at Social Innovation Ventures. And joining Dr. Ostrovsky are Dr. Corey Waller, who is a Principal with Health Management Associates, Dr. Kelly Clark, who is Immediate Past President of the American Society of Addiction Medicine, Ms. Kate Berry, who is Senior Vice President of Clinical Affairs and Strategic Partnerships at America's Health Insurance Plans, Dr. Shari Dubester, who is Executive Vice President and Chief Medical Officer at Beacon Health Options, and Dr. Ling, who is Acting Chief Medical Officer at the Centers for Medicare and Medicaid Services. Their full biographies are available on the event website for you to access, and please note that we will be taking questions from the webinar audience during the last 10 minutes of the session. So please use the comment box on your screen to ask a question. And now I'll turn things over to Dr. Ostrovsky. Thank you.
Great, thank you so much, Liz. Really appreciate it, and excited to have all of our great panelists. Just as a logistics FYI, Jarrett, I just sent you an email because I think Shari's internet just went out. So I emailed you with her cell phone, and I emailed her with your cell phone. So I hope you guys can figure that out before it's her turn to go. Otherwise, we'll just wing it. And with that, really excited to have you all participating. We're talking about a really important topic, which is building a health system that is equipped to prevent, treat, and manage opioid use disorder. Again, I'm Andrey Ostrovsky, and I'm really honored to have an incredible group of true experts on the subject. Before I jump in and hand over the reins to our experts, I wanted to just set the stage a little bit. If we could go to the next slide, please. Thank you. For disclosures, all of my conflicts of interest are on this website, so take everything I say with a grain of salt. Next slide, please. In terms of how the flow will happen, I'll give this quick introduction. Each of our great panelists will give some remarks over a 5 to 7 minute period. We'll then have a moderated Q&A that I'll prompt our panelists based on some of the themes of what they're discussing now. And I'll also leave some time to make sure that you, the audience, can chime in with questions. I will be keeping an eye out on the Q&A section. So if a question pops up in the middle of the session and it's really topical and timely, I'll try to incorporate it, but we will leave some time at the end. Next slide, please. Thank you. So for context, I mean, we can't have a conversation really about any chronic condition, including opioid use disorder, without talking about what is really top of mind from a public health perspective. I gave a talk about 1 month ago and shared a slide similar to this. At that time, there were about 40,000 deaths in the US. As of this morning, over 91,000 deaths, which is absolutely terrifying. And we see here some of the trajectories of where COVID is still to go in terms of mortality. This doesn't take into account all of the morbidity. Next slide, please. And speaking of morbidity, it's not just healthcare or medical morbidity. There's also the upstream health determinants, namely socioeconomic status, and employment rates have pretty significantly plummeted. So when I gave this talk a while ago, it was at 22 million folks that are unemployed. And next slide, please. We're now at 39 million, and that is 15.9%, almost 16% of the working age population. We see here relative to the Great Depression just how high that very steep peak is in terms of unemployment. And this has pretty significant implications for behavioral health issues, particularly around opioid use disorder. Next slide, please. There's some pretty powerful research done by Case and Deaton that looked at some of the drivers around what has been popularized as deaths of despair, so deaths from overdose, alcoholic cirrhosis, and suicide. And there was a pretty strong link between socioeconomic status, in particular income, and educational attainment. And what this data show is middle-aged, non-Hispanic whites in the United States mortality rates relative to other countries. Now, a slide I don't have here, but something that is emerging as a pretty prominent issue around mortality rates is the disparities that are emerging around COVID. And I apologize for the background noise. It's my kids outside yelling and screaming. So I'm gonna close that window. Yay, time of COVID. The disparities are just such a critical issue to look at here. And when we think about COVID, we think about unemployment rates and we think about associated morbidity and mortality, there's a unfortunately perfect storm for turning back all of the progress that has been started to make around decreasing overdose deaths. Next slide, please. Almost there, there we go. And so how do we think about the future state of the opioid use disorder prevention, treatment, and recovery system? And I have to give credit to Dr. Corey Waller, who introduced me to this really great concept of the 4 C's. And those include capacity, competency, consistency, and compensation. And throughout the remarks that we'll hear today, I'll be bringing us back to these 4 C's and thinking about some of the health plan perspectives, some of the government perspectives on these issues, some of the provider perspectives on these issues, and most importantly, we'll really need to dig into some of the consumer, people with lived experience perspective on these issues. And so capacity, just to be precise here, is the system correctly sized to fill the needs for the community it is serving? From a competency perspective, does the system have the right education, training, and evaluation of all aspects of the treatment system, including prescribers, therapists, administrators, and peers? From a consistency perspective, is the system delivering high quality care? And from a compensation perspective, is the system paying the right amount for the right things? Next slide, please. And so we'll now have a few remarks from each of our panelists, and each panelist will have about 5 to 7 minutes. And panelists, I think you all have generally worked with me before. I'll really keep us to time and nudge us along. We'll have plenty of time for Q&A. And next slide, please, if we could. There we go. Perfect. So we're going to start off with Corey, and Corey's going to elaborate on some of these 4C concepts. And we'll go over to Kelly, followed by Kate, Shari, and then Shari, and hopefully Shari Ling will be able to get her internet back in time. And with that, I'll hand it over to Corey.
Great, thanks, Andrey. I appreciate that. And as we try to work through this, the 4 C's, and there's probably a 5th one hanging out there called community, but we're going to focus on the other ones, that we can really, as a system development piece, approach in a way that's helpful. Next slide. If we look at those 4 C's again, this is not an opioid treatment system. We have to build an addiction treatment system, and that includes co-occurring capabilities and all of the aspects. And so I always tell the people that fund me to help them build systems, just secretly, even if it's called opioids, you're getting an addiction treatment system that we build, because to build one is just a fool's errand in a sense, because the way you treat opioid use disorder has its specifics, and it's a pretty narrow approach in a number of different pathways. Alcohol is a little different. Methamphetamine is 180 degrees, and then everything in between. So when we start to look at building the system, when we talk about capacity, it's not just about the capacity to treat people with an opioid use disorder. It's about the capacity to treat people who would like treatment for addiction, period, and right-sizing that system. So let's talk about that one at the beginning. So next slide. If we really dig into capacity, then what we look at here is all of the levels of care that it needs to be delivered in. So this is not a matter of we just have to get a whole bunch of people who can write for a medication, or we just need a lot more therapists, or we just need a lot more inpatient beds. The answer is yes, yes, and yes when it comes to opioids, but also for addiction as well. But also what I don't want to do is overbuild certain aspects of the system. And this is where kind of the local community and regional payment systems and capabilities of those around really come into play. Because if we're looking at level 1, that's great if we have outpatient treatment. But if you're sicker than what level 1 needs and you need to be in level 2 with greater interaction over time, you're more likely to fail at level 1. And then if you have an unsafe recovery environment and you need to go to level 3, then we need to have that available, or you need higher level withdrawal management. We need to be able to apply that. And then for level 4, for the sickest patients, we don't have very many of those, and very few people can identify a location in which there's an available bed. Not to mention what we've talked about earlier, which is a complete dearth of delivery capability within hospital-based systems, with the exception of Dell in Austin, which, funny enough, was the first hospital I ever worked at as a teenager, working in the EKG, or just looking at banks of EKGs. So yeah, bravo for Dell. Next slide. So competency is the next one after this. And with competency, we have to really think about what we mean by that. And I loved the slide earlier that talked about how teaching is not necessarily learning. I think that's a really important thing. And it's not just about teaching somebody about the pharmacology and implementation of certain medications. We have to make sure that the therapists that are delivering the care for these patients really understand the approach to cognitive behavioral therapy for addiction, for co-occurring illnesses. How do you comport those two? How do you work on all the early life trauma? What if you're a therapist in a jail or a prison? The approach to that subset of the population has to be framed differently, and the knowledge base is there. So competency is not a general overarching 30,000 foot view competency, but really narrow and specific to what do you do and what is the scope of work you provide. And this has to go all the way to administrator competency. If you try to drop an addiction treatment clinic into an outpatient group, and they put you in with the normal, I have a medical assistant who takes your blood pressure, and I have a nurse who, does some education, and they give you 15-minute appointments, it's just going to fail. It's not going to be effective. So the administrators need to know everything down to the nuts and bolts of how do you do group-based visits? How do you make sure that an intake visit has the right amount of time? How do you make sure that you bill for combined care in the appropriate way? And so the administrator competency is important. And then peer competency is not about teaching them about addiction, because they teach us about addiction on a regular basis. It's about teaching them how to work within the healthcare system so that they can get the most done for those that are trying to be in recovery or stable in recovery. Next slide. And this has to be followed by, how do we really approach consistency or quality? And this is the full-scale implementation of structural measures and outcome measures. What is the service array or package of deliverables that we should expect if somebody shows up to a level 1 or a level 2 or a level 3, and that insurers can feel like if they pay $1, they're getting $1 worth of something back? Because this is the real issue is, people say, oh, I treat opioid use disorder. Really? What do you mean? Do you just write a med, or I used a couple of words of motivational interviewing, or do you have a full array of services that when they walk in, they're doing you have an official assessment tool. You have a level of care placement capability. You refer them when they don't meet your level of care, so that it's not that you're a hammer, so everything is a nail, and making sure that they can move through this system. And then the fidelity to the ASAM levels of care is important, because people want to interpret it in the way that best suits them and their payment model. And we need to switch that to kind of really the best of the best, being high quality delivery systems, like we have stroke centers and trauma centers and things along these paths. And then the last one, which I think is important for the sustainability of this system, which will be on the next slide, is compensation. And when we talk about compensation, we need to realize how ill-prepared the addiction treatment ecosphere is for doing anything close to value-based payment. If we just look, if we look at even fee-for-service, and we're going to try to go up to MAPIA and pay at parity. If we look at things like in Colorado, their BHOs have $650 million a year, which sounds like a lot until you look at what they need when you calculate it out if it was at parity, which is right around 4 billion. So at this point, we don't have in most, really any state, the ability to deliver high quality care on a consistent basis and make sure that people have access to education and consistent competency and training. And when we talked about what Aetna was doing earlier, when they started looking at academic detailing, this needs to happen in wholesale fashion across this. And you can't do that if you don't compensate with an appropriate margin for somebody to build this into their HR package and their risk mitigation package in their system. So when we look about how are we going to pay, it's not just about the amount that we pay. It's what is the type of pay that we do? Is it for a service or an outcome? Is it capitated or is it for a population? You know, how do we look at this as it goes through? So I would say that the one that I usually add, we'll keep it tight on this one, is the community, because this is also a huge one, which is talking about what is the community role? Well, we've talked about that. We've talked about NIMBY. We've talked about structural racism and how it actually alleviates access to direct care in certain locations. So if we're really going to build a system that treats people with addiction on a consistent and predictable basis, and then know we're getting our money's worth when we pay somebody to do that service, we have to make sure that it lives within a community that can be as predictable and helpful as the remainder of the service line.
Awesome, Corey, excellent, thank you. You mentioned ASAM criteria there a couple of times, and I think it's very appropriate that we have Kelly Clark, Dr. Kelly Clark, speak next, who is the past president of the American Society of Addiction Medicine, a provider, policy expert, and I think we've got a lot of great learnings to come here. So Kelly, the floor is yours. Thank you.
Oh, thanks, Andrey. Next slide, please. So before we can start answering this concept of how to build a health system that's equipped to prevent, treat, and manage OUD, or opiate use disorder, we have to start at the very beginning, which is let's treat addiction like every other chronic disease. Next slide, please. When we think about addiction as a chronic brain disease, the implications there are very clear. You know, a brain disease means there's stigma involved, always. Chronic disease, we know how to approach chronic diseases, right? We know what the outcomes are, which the outcome is not perfect adherence to a treatment plan. Do you always do what you're supposed to do? But what we're trying to do is use a holistic approach to help people manage their disease state, using a medical, multidisciplinary kind of approach. And the outcomes, because it's not an acute thing from which you recover, but it's a chronic disease, the outcomes are around decreasing the morbidity and mortality related to that disease state. So the medical complications and the early death risks related to that disease state, decreasing the total cost of care, and increasing functioning, or basically stay alive, become healthy, stay out of hospital, and get back to work. This is how we look at every managing outcomes. These are what we look at for managing every chronic disease state. Next slide, please. So let me just throw out a couple of pieces of language to tee things up when we're talking about treatment. Okay, remission is what we physicians do. We look for remission in patients, which means the person's without active signs and symptoms of their disease. That's remission. It's a medical goal. Recovery is a process by which a person lives their best life and manages their chronic condition. Recovery is a whole person goal. The medical goal is around remission. But we don't think a person is a bad patient if they can't achieve remission, right? And simply treatment adherence does not mean recovery. So keeping that in mind, what are our goals? So next slide, please. When we think about this addiction as a chronic brain disease, the implications are physicians are involved with care. Medical care is based on evidence-based, a core of best practices where there is a longitudinal, individualized biopsychosocial treatment plan with quality metrics, and healthcare dollars are used to pay for treatment at parity. Next slide. So just think of this as another disease state. We use an individualized treatment plan based on structured best practices. Just individualizing something is not sufficient, or just using a cookbook of structured best practices is not appropriate. If we start out by thinking, how are we going to approach a chronic disease, the same way we do with other chronic diseases, it can inform every step in building what we need. Right provider, right dose, right place, right kind of treatment for as long as necessary at a specific point in time during the course of that patient's chronic disease management. So next slide. Where are we now? Well, you think about what does it take to treat a disease? People need to start out by getting a diagnosis. They need to be evaluated by an appropriate clinician. People don't just walk in and say, hey, I have got XYZ disease, and treatment starts. There has to be an appropriate clinician who knows how to do the examination and evaluation and establish the working diagnosis. Then the clinician works with the patient to make an evidence-based treatment plan. They work the plan, they implement the plan, deploy those resources, and then you go back to the top again. Evaluate by the appropriate clinician. How well is that plan working? What do we need to change, etc.? That's how we treat any kind of chronic disease. Next slide. What we're dealing with here is, in the United States, we lack an adequate infrastructure capacity to treat the population with addiction at all stages, at all levels of care. We have never built an adequate evidence-based treatment structure. Next slide. So we talked a little, Andrey mentioned the ASAM criteria. I'll talk about that in a minute. Continuum is basically it's the ASAM criteria, which is in an electronic evaluation mode. Next slide, please. And I do want to mention to everyone that this is being recorded, and the slides will be available after this talk. So I know I'm going through these quickly, but these are resources that will be available to you later. And Corey mentioned the continuum of care. There's not just an inpatient or an outpatient, the same way, inpatient is when people sleep over. A nursing home is inpatient and an acute care hospital is inpatient, but they're different levels of care, right? An outpatient visit where you see your doctor once a month is different than a cardiac rehab program where you go regularly several times a week and go through a protocol. Both outpatient, but different levels of care and programs. And that's what we see with the ASAM criteria. And the ASAM criteria, they delineate these levels of care and define those elements. Next slide. So say a person has had an evaluation and it's determined what kind of dose of care they need. So they need to go to an inpatient, say a medically kind of supervised or monitored withdrawal kind of program. There is currently no way for the patient or the payer to know whether a treatment facility even has the capacity or capability to deliver that level of care. The programs are licensed by states without consistent criteria. There's one state that made up their own ASAM criteria, which I find really interesting. They made up their own ASAM 3.2. What is this? And when we look at what's really even out there in the programs, the majority of treatment programs in this country do not offer patients medication for addiction treatment, methadone, buprenorphine, extended release naltrexone. They don't offer what we consider to be the baseline essential element of care in their program. Next slide. So when we look at what is going to be needed, looking at what are the elements in each of these levels of care, which are about staffing and kinds of care and hours of treatment and et cetera, and utilizing this as a baseline to make a consistent floor is what we're going to need to do for consistency standpoints. And next slide. Currently, people have heard of the Joint Commission and for CARF, which are accrediting organizations, but when they accredit for at a very high level, and the kinds of things that they would accredit for are not the kinds of things that are looking at the actual baseline quality of care delivery that we're talking about with something like this kind of criteria. ASAM and CARF have partnered and have developed a level of care certification program for which payers and patients and their families and all kinds of folks could actually know that there's been a third party that's come in and looked at the protocols and policies of a program to even say they have the capacity to deliver appropriate care. So next slide. Thank you for your kind attention, and I'll look forward to our question and answer time.
Wonderful, Kelly. Thank you so much. That was wonderful. I have a ton of questions. I'm going to hold off on those questions, but I think this is very timely to think about how are payers thinking about a lot of these issues. And with that, we have Kate Berry, who is the Senior Vice President of Clinical Affairs and Strategic Partnerships at AHIP. I'm excited, Kate, to hear your perspectives. Oh, Kate, you might be on mute. Still might be on mute. Oh, yeah, there we go.
All right, thank you.
Yeah, we can hear you. Thank you.
Very good. Thank you so much for including me in this conversation. And for those who might not be familiar with America's health insurance plans, we represent the health insurance industry, all different types of health plans, Medicare Advantage, Medicaid managed care, commercial, employer-sponsored, individual market. And next slide, please. Very briefly, I mean, we're very much focused on the consumer experience, the patient experience, promoting affordability and value. Next, please. Our plans think about this whole issue really holistically. So we think about prevention, early intervention, and supporting treatment and recovery. And so that includes really thinking about how do we reduce opioid prescribing? How do we better manage pain care, for example? Those are ways to sort of reduce the incidence of addiction to opioids. So we have a number of initiatives underway there. We've got a very active member work group that I've had the pleasure of leading for several years on clinical issues, policy issues related to opioid addiction. And that includes really looking at leveraging the CDC guidelines around opioid prescribing and pain treatment, and developing some measures to consider how provider performance measures up with the CDC guidelines. So that's something that we have tried to do to kind of promote sort of the front end of all of this. Next slide, please. On the treatment and recovery side, we've focused in a number of areas here that includes promoting, really looking at, how do we engage clinicians? How do we engage patients? How do we engage the families, the caregivers, et cetera, to ensure that we're treating this, as others have said, as a chronic condition, that we reduce stigma, that we integrate care with the primary care practice as much as possible. That we really try to look at, are there alternative payment models to encourage alignment of incentives among everyone in the care process to drive better outcomes that promote ongoing care over time. Make sure that we have the right team approach. CMMI has even considered different alternative payment models for substance use disorder that we're seeing making a difference in Medicaid managed care programs, being piloted by plans including AmeriHealth Caritas and others. I think it's also really important, especially right now with COVID, to think about how do we leverage telemedicine to promote increased access. We all know that we have capacity issues, not enough providers are providing or have the DEA waivers to support medication-assisted treatment. How do we use telemedicine to reach people in these times? And we have a number of different examples there. We're seeing significant increases in the use of telemedicine to provide this type of care. And I think another area where we see some challenges that others have also said relates to measurement of quality. How do we make sure that we have the right measures in place, the right infrastructure in place to promote measuring and improving substance use disorder treatment in this era?
Perfect. Thank you. Thank you so much, Kate. So I think these are Great questions, and I'm excited to dig in to see what might be some answers to those questions. What is working or what isn't working, and why? And I think Shari, Dr. Dubester, is operating out in the field, running a plan, leading at a health plan. And Shari, I'm excited to hear your remarks and see what might be some of the answers to those questions of how to achieve those 4 C's that we talked about.
Thanks so much, Andrey, and I'm glad to be here. And I'm actually wearing 2 hats today. I am representing Beacon as the Chief Medical Officer. And for those not familiar with Beacon, it is a mental health and substance use disorder management company with EAP services and a bunch of specialty programs. But I'm also representing Anthem because Anthem has purchased Beacon, so we are now under the Anthem Inc. umbrella. Luckily, I was at Anthem for 18 years before going to Beacon, and it actively involved in the opioid use disorder strategies there. So I think I can fairly represent both organizations. So from a payer perspective, our focus has been and really continues to be approaching opioid use disorder holistically. And I'm using the term holistically broadly. Holistically can mean that we're focused on spanning prevention to recovery. It means that we're focused on whole person care, and we've heard many speakers talk about this today. It certainly includes thinking about physical health and behavioral health as well as substance use. It means thinking about the broader well-being, which starts getting into social determinants of health and then starts touching on disparities, and all of those areas are very important for whole person care. And then finally, from a payer perspective, Beacon is not an island unto itself, nor is Anthem or any other payer. The focus has to be on collaboration with providers, with external organizations, and I'll give a few examples of that as we go on. So you can go on to the next slide now, please. So there's a lot on this slide, and I'm gonna only focus on 2 slides and really try to make this one come alive from a prevention, treatment, and management perspective. So starting with prevention, under which I would include screening and early identification and intervention, really more in the bucket of secondary prevention. One area that we've focused on now for several years is working with primary care providers to increase the rate of substance use screening and assessments, that expert model of screening and brief intervention and referrals into treatment. We've been promoting the adoption of screening and reimbursing for it under CPT2 codes for since 2016. And we have seen a steady increase in those rates, most recently a 60% increase actually from 2018 to 2019. So the numbers are still not where we would like them to be, but we've certainly seen an ongoing increase. We've also been doing a lot with Project ECHO, and for those not familiar with Project ECHO, you can think about it as a learning collaborative that started with hepatitis C out in New Mexico when there really weren't enough specialists to treat hepatitis C, and there needed to be more upskilling in terms of the comfort and the skill set of primary care providers to treat hepatitis C. It's actually a great model for opioid use disorder as well, and substance use more broadly, because we need to upskill and increase the comfort of our primary care physicians and extended providers in those practices to feel comfortable addressing opioid use disorder. So we have launched 3, they're called hubs, in Connecticut, New York, and Florida, focused on opioid use disorder, and have further expansion plans. Anthem has also pursued some funding collaborations with a couple of university systems to basically make it more affordable to drive additional provider uptake of the ECHO model. We've also done a fair amount on analytics, and analytics are important for a few reasons. One is that predictive modeling helps us risk stratify our populations that we manage so that we can ensure we're intervening in the right way at the right time. We also incorporate fairly robust pharmacy analytics, which helps support safe prescribing patterns. And use analytics around fraud, waste, and abuse to really focus on problem areas like toxicology lab services and sometimes providers where we're concerned about overutilization and other patterns of concern. And then finally, in this area of prevention, we focus quite a bit on integrated approaches to behavioral health and physical health so that we can identify members who are struggling early. Moving on to treatment, the focus is all about providers. We're looking for integration and we're looking for innovative treatment models. A core component has to include medication for opioid use disorder as an option. Doesn't mean that everybody will choose to be on a medication, but it has to be part of the conversation. And then we look for innovative delivery models, whether it's in the home, whether it's facility-based, but weaving in 24/7 access and crisis support. But all of those models have to also really embrace quality metrics, a focus on outcome metrics, and an appetite in the bigger picture to move from fee-for-service to more of a value-based reimbursement model. Telehealth and digital expansion in terms of digital tools was already a focus area before COVID-19, and I'll certainly spend a little bit of time talking about what's happened since COVID-19 in terms of that. But what's been so interesting is that it's not just the treatment program components. The technologies now are able to add applications such as geo-monitoring, social networking components. It really becomes a kind of a rich ecosystem, if you will, of capabilities that we're very excited about. I mentioned quality metrics, and we have definitely a direction going towards preferred provider networks, and we'll be piloting that in New York later this year, and tying that to value-based programs. And on the Anthem side, there's a set of 37 substance use disorder facilities that are involved in a value-based model that is currently running. From an external collaboration perspective, which is extremely important, I've enjoyed working with Kate in the past around some of the AHIP work. Shatterproof is doing very important work in terms of bringing together a broad set of stakeholders so that we can improve the adoption of evidence-based care and strive for as much consistency as makes sense. I don't think we want to solve for this a million different ways when it comes to metrics, when it comes to value. And though we all need to respect the independence of these companies, there's a lot we can do in common. And I think it's extremely important, not just for OUD, but certainly it's great to be working from that angle in this condition. Blue Cross Blue Shield Association is working on substance use disorder centers of distinction, and we're a part of that. And we're also piloting with Alliance for Addiction Payment Reform a pilot to look at how we can build in a kind of a case rate essentially that allows coverage of components like peers that sometimes aren't covered, especially on the commercial side. And finally, from the perspective of enhancing management, we have been gravitating more and more towards field-based staff. We still use telephonic types of interventions, but we in general find that field-based staff is very important. We also are scaling pilots that look at working very deeply with our facilities to introduce patients to the option of medication from the time of detox, and then ensuring continuity of care. And then finally, a much deeper focus on social determinants of health and really trying to get that data. If you go to the next slide, I'll just make a couple of comments on the world of COVID.
And Shari, just really quickly, 1 minute if we can.
Yes, I will do this next slide very quickly, because really what it sums up is that there's been a dramatic shift to virtual care delivery. Overall, for us, there's been an increase of 5,000% in overall mental health adoption by behavioral health providers. And we've been spending a tremendous amount of time supporting our providers so that they can successfully deliver care via telehealth, including for opioid use disorder, including in terms of medication treatment, and including higher levels of care. We've had many providers attend weekly webinars, and we're also shifting many of our services, including services we have delivered in the field, like peer support, to deliver via telehealth. So there's a lot here, and we can certainly talk about it more during the Q&A, but it has been a time of real challenge, but also opportunity. Thank you, Andrey.
Excellent. Shari, thank you so much. I think Anthem is very lucky to have you back. I've definitely learned a lot from you and appreciate your comments here. Anthem and Beacon are large payers, but the largest of them all, CMS. To wrap us up here with our comments, we have Dr. Shari Ling, who is the Acting Chief Medical Officer at CMS. And Shari, I'm very excited to learn what you have to say. Thank you. Oh, and I think you might be on mute also.
Yep, your excitement is actually overshadowed by my excitement for the ability to actually connect in. So it's really great
Hey,
to
we
see
did it.
you all and have a chance to actually learn from you. Greetings, colleagues. And thank you for the kind invitation to be part of this panel. And Jarrett, shout out to you for the technical assistance. So if I could have my next slide, please, which is my obligatory disclaimer slide, that this is for really for purposes of public education and engagement, but imposes no obligations. I have no financial conflicts to disclose. Next slide, please. So just as a reminder, CMS and the beneficiaries whom we touch upon, we cover approximately 1 in 3 Americans, and the challenge for us is that it is a increasingly complex population of beneficiaries. So, you know, when we think about the challenges and the characteristics that you've described in the 4 C's and how to approach this, we really want to enable maximum and optimal use of the policy and program levers to meet the beneficiary healthcare needs, but it becomes very challenging sometimes because those needs are quite diverse. Next slide, please. So this is a graphic depiction of our CMS strategic vision. There are 16 priorities laid out, and the yellow arrow just illustrates that fighting the opioid crisis is one of the agency's priorities. We do focus on, you know, a person-centered approach, and so as we think about transitioning from volume to value, we really are trying to think about how to keep the beneficiary, the patient, at the center of everything. Next slide, please. So back in 2019, we finalized a CMS roadmap, which actually built on the HHS roadmap, being that CMS is one of the agencies within the Department of Health and Human Services. And I'm just going to take you through a couple of the updates, being that we actually are now in 2020, and 2020 is actually going by pretty quickly, but really keeping things at a very high level. So I think it's more important for me to convey how we work, what the opportunities are, the program and policy vehicles, and try to circle back and tie them to as many of the C's as I can. So next slide, please. So as you can see, the pillars of the CMS roadmap to address the opioid crisis really is on prevention, treatment, and also use of data. And you know, when we talk about prevention, I was able to hear some of the prior speakers, and we're not talking about, we are really trying to focus on prevention by way of better pain management or optimal pain management. And as you know, some of our work included finalizing the acupuncture national coverage determination as a vehicle to improve pain management for chronic low back pain, as just one example of prevention. And then the second pillar being treatment, enabling access to treatment for OUD. And finally, to be able to really unleash the power of data. We have multiple data sources, including claims that we have used for heat mapping. But again, this is in the Medicare population. We also are bringing online the Medicaid data as well. Next slide, please. So as we are moving forward, we are certainly using all of the program and policy levers that we have at our disposal to prevent, better manage, or better treat, and also be able to release to the public data for action. across all CMS programs, and being that CMS's role is really that of a payer, the most robust data that we have really comes from the administrative claims. Next slide, please. So as we are going forward, I wanted to call attention to the Support Act, and there are numerous provisions in the Support Act that CMS has a responsibility for implementing, and this is just one of them, but it's an extremely important and broad provision, Section 6032, which there are several requirements, one of which was to consult with the Pain Best Practices Task Force that HHS and the OASH stood up and completed. But this results in a action plan to address the opioid crisis, utilizing CMS programs and policy levers, but also will result in a report to Congress. Now, the action plan, we also held a public meeting to inform the shape and content of this action plan, and also then reviewed all of the recommendations that came in by way of public comment and the public meeting, according to a pick chart, if you will, that assessed feasibility by impact. So what you will see when we're able to release the action plan and the report to Congress is those recommendations that we believe are both actionable and also of high impact across the care settings. Next slide, please. So this is just a graphic depiction of the different programs and policies that CMS has authority to implement. And I would like to just take a moment to try to connect them with some of the C's. I don't think I have all of the C's covered here, but as a payer, compensation is it's kind of one of our major roles as part of HHS. And again, we are focusing on that translation or transition from volume to value. Heard Corey's opening remarks, and understand that each population of patients and also providers is at different points in evolution towards value. In order to get to value, we actually need robust quality measures that can really speak to improving health outcomes in the population that the measurement is intended to be applicable to. When it comes to competency and consistency, CMS also has authority to set the health and safety standards and expectations for Medicare participating facilities on a national scale. And so, we have, and I think the exception there is in the health professional space, where CMS does not have authority for oversight over healthcare professionals. But nonetheless, those standards can then be, we can survey to and assess compliance with the conditions of coverage and participation. So I think that is one way that we address both consistency and in a way, competency. I think capacity is another aspect, though, that in the public health emergency with COVID-19, we actually look to enhancing flexibilities and use of technology by way of telehealth provisions, as broadly as we could, really attempting to meet the needs of healthcare delivery so that it could provide access to our beneficiaries in a broad and unencumbered way. We also enabled workforce flexibility so that not only facilities could get patients where they needed to be in the event that they needed to meet the surge capacity, but also for healthcare professionals to be able to really function at the top of their license. So there were enormous challenges on many levels, and the kind of information that I heard shared today is exceedingly helpful to us as we are evaluating and looking at, what have we learned through this public health emergency? Where are there are opportunities to actually improve healthcare delivery that results in better access and improve outcomes. So the kind of information that you have shared would be really, really helpful for feedback to us. And we understand there remain gaps and hurdles that we must be attentive to, but we have the opportunity to think about solutions as they apply to the various program and policy levers that I have displayed here.
So Shari,
Yes.
just really quickly, if we could have just maybe 30 more seconds, and we'll jump into Q&A.
Okay, next slide, please. I think the following slides are all resources, which is probably the best part of the presentation, so we can make those resources available to the audience. So thank you very much.
Perfect. Shari, thank you so much. And thank you to all of our panelists. I want to jump right in. One of the things that I think are applicable across all of our panelists' comments is the issue of payment, in particular around telehealth. Right now, we are in a state of public health emergency, and so 1135 waivers are in effect. But once the state of public health emergency goes away, those waivers and the associated flexibilities go away. There have been some plans across the country. I think the most recent one I saw was Blue Cross Blue Shield in Tennessee that put out a statement and said, moving forward, they are going to reimburse telehealth in parity with in-person services moving forward. And maybe I'll start with you, Shari, Dr. Dubester, about what your thoughts are moving forward beyond the end game of COVID and towards a steady state of the kind of what will be, I guess, the new normal. What are your thoughts about reimbursement of telehealth in parity with in-person services beyond COVID?
Yeah, I think there'll be, well, a couple of things. One is, I think in the environment of COVID, I think CMS has done the right things by just completely broadening telehealth coverage. I think as the situation stabilizes, we do need to go back in and look at, what services do best with telehealth? What about telephonic only versus video? Because you lose, obviously, some significant effectiveness aspects with just telephonic. For higher acuity, is really doing it via telehealth adequate? What about hybrid models that bring together in-person and telehealth and digital tools to amplify? And so I think we're going to be looking at how you bring together newer, more innovative models of care. But telehealth, which many of us have been trying to nudge along for a few years, took a giant step forward, and a lot of that is great. And we certainly want to make sure that we're reimbursing in a way that continues to support its deployment in the best ways possible. But I think we also have to critically look at where it does its best and where we need to combine it with in-person and other components to make a very healthy ecosystem of care.
Perfect. And I'll have everyone comment on this, but maybe I want to, if we could go to Kate Berry. Kate, I'm wondering, is there a role for AHIP to play in the convening function to aggregate some of those approaches around evaluating telehealth, and to what extent should it be incorporated into a standard of care so as to eliminate some of the redundancy or siloed recreating of the wheel, health plan to health plan to health plan? Any thoughts on AHIP or another convening entity, perhaps National Academies of Medicine, role in something like that? Oh, you may be on mute again. Sorry. I like it to build the suspense. It's fantastic.
I thought you were muting me. On purpose.
No.
So yes, this is something we're really giving a lot of thought to. And I will say back in late March, you know, our chief medical officers were saying, look, we need to open up telemedicine as much as possible. So we agree, I agree with, you know, what Shari said, that to open up what can be provided through telehealth and to expand access in that way is really, really important. And we're starting to think about, so what changes, what of those changes that have occurred should be sustained? And maybe not everything. I think it's important to really think about, you know, what needs to happen, you know, in person, what can happen virtually. I do really believe that a lot of what we're seeing in terms of virtual care can be sustained and can augment capacity in these areas. And yes, we're going to try to really think about, both from a you know, use standpoint and you know, where the impact is and where the growth is and what the patient experience is and what the provider experience is and what are the policies that we want to see carried forward. So absolutely, we, you know, we're working on that. We're thinking about it. It's not an easy thing to look at, because if you think about it, this has been only, you know, 2 months so far, and you know, there's brand new codes that relate to a lot of this care and what type of technology can be used and how that's been expanded, in particular under Medicare as well as elsewhere. So absolutely, I think we all need to work together to figure out how do we carry forward and make sure that we fully leverage telemedicine in a way that helps patients and promotes affordability and value in the long term.
Great, thank you, Kate. And before I go over to Dr. Clark, 2 things that really stuck out from what you said. One is you pointed out that you all are pulling out the collective views of many of the chief medical officers at your member plans. And what that makes me think of is, to what extent are we as a collective group of thought leaders pulling out the consumer voice, the person with lived experience voice, to inform our telehealth policies? The other thing that struck me about what you mentioned, Kate, was the types of providers that telehealth policy will impact. And I think peers, Shari Dubester had mentioned peers. Well, to what extent is telehealth reimbursement going to be at parity permanently for peers or other types of providers? Kelly, Dr. Clark, could you comment on some of those themes, or specifically the question of what is the correct path forward for permanence of parity of telehealth payment relative to in-person care?
Okay, how much time do I have, Andrey?
Let's do 2 minutes.
Excellent. Okay. So what we're doing right now, and kudos to CMS for jumping on this, we are providing virtual visits that are not consistent with the extreme regulation that we've had around telehealth and telemedicine in the past. And that's incredibly important right now during the crisis. And thank you, CMS, and thank you, SAMHSA, for relaxing, and thank you to EDA for relaxing a lot of what you've done as well. When we're talking about doing virtual visits, you know, let's talk about some of the areas where this is really important and a positive, and somewhere where this is not addressing our issues. So when we're doing things that look like an ASAM Level 1, ASAM Level 2, when we're looking at individual psychotherapy, physician visits, etc., the way we would do with any other medical disease, I want to talk about how we deal with every other medical disease, okay? Here is where virtual visits are extremely helpful, okay, and very, very easily integrated for those who have access to the technology as patients, okay? We have a big problem with a homeless population, a criminal justice population, rural populations that don't really have access to internet type capabilities and so forth. And this is where some of that audio only has become so incredibly important during this epidemic. But when we get into levels 3 and 4, where people need 24-hour care, they need clinical oversight, 24 hours, not sober homes, not residences, but clinical care, that's not something you can do by telehealth. That's something that you have to put together. And I've been very concerned to hear in many states where the payers are not providing payment, not only at parity, but at all for treating addictive disease using virtual visits. And I'm also concerned to be hearing from some sectors about diversion of medication, particularly buprenorphine products. And as we addictionists know, buprenorphine is diverted around as much as your antihistamines and your antibiotics are diverted, your insulin type medications. We've got diversion of lots of kinds of medication. So one thing to allow this to continue would be to look at that kind of rate of diversion versus other chronic care kinds of medications. So we have to set ourselves up to gather the information that's necessary to show what we believe we're seeing out there in the community. Because before we can really say, well, yes, this is useful and we need to continue to pay for this, which we absolutely do because we've got lots of barriers to care, we're going to have to make that case using some data that we need to collect.
Wonderful. Thank you, Kelly. And just to echo what you pointed out about appropriateness of telehealth before I go over to Corey, to Dr. Waller, one of our attendees and actually one of our persons with lived experience work group members, Edna Boone, pointed out an excellent quote, which is telehealth can be a great tool with appropriate guardrails and making sure that we don't create a have and have nots scenario around telehealth. So to your point, Kelly, Corey, you work with a lot of states in a lot of different settings. What have you seen that informs the correct path forward around telehealth payment, particularly around tele-MAT?
Well, I think, just to be blunt and honest, which is my forte.
You blunt and honest?
I know, it's crazy. But the reality is we don't know what people do when they get on the phone. We don't know what they ask. We don't know how they interact. We don't know if it's the right person on the phone. I mean, how are we identifying that it's the correct person that we're having an interaction with? I mean, even just checking an ID. I think that those are real issues that we have to think about. On the other side of that, there are now people in rural and remote areas that have access to treatment that didn't have it before, that otherwise would have been at super high risk for overdose and death. So we need to, in pretty rapid fashion, in conjunction with the federal side and the state sides, put out some guidance on what is a solid addiction-based telemedicine evaluation and interview. What are the components that need to occur? What are the ways in which you should be checking ID? How do you document it appropriately so that when you do bill for it, that people who pay for it know that they paid for something? Because, when you look at fraud, waste, and abuse, this is right for that because it's new, and it seems to be the American way to rapidly find out how you can jump into something without it. I've had 50 calls from people who want to start a telemedicine company. And I will tell you, we're going to be, if we don't pick up speed, we'll be pretty far behind on something that I think, quite honestly, is the future of healthcare in this space, especially with the large amount of remote and rural areas that we have in the United States without direct face-to-face access with a clinician. And I got to say, I'm scared to death about us ramping up some of this prescribing and then the DEA pulling that rug immediately out with very little, landing path, and without coming out with some intermediary step or something, because I think that the risk of mortality from that is huge.
Thank you, Corey. And so, Dr. Ling, Shari, you've heard some thoughts about what the future state of telehealth payment should look like. What are your thoughts about how CMS could help facilitate a thoughtful, systematic approach to what that should look like?
Yeah, so we are in rulemaking, so there's not a lot I can say
Sure.
about details, but I will say I think the questions that you're asking of yourselves and of the system, I think those are really important answers. Even just knowing what is the service that is delivered, and Corey, to your point, to whom, and what. Again, it's still about what does quality look like? What might be some minimum standards and how would we know? I think, you know, we always have to be willing to accept that the alternative hypothesis is true if that's where the data takes us. So I think this is a tremendous opportunity for us to learn. And as I was hearing and listening to the conversation, I think this, the challenge we have is that we have such need. We have to go fast, but we have to be thoughtful and methodical and measured at the same time. So, you know, even knowing what good outcomes, are there a few core outcomes that we can all agree upon, which we would anchor, you know, the questions around? That is a step forward. And having a community like this who can learn in action, I mean, not learn in action, but learn in action would be, I think that can help, you know, propel the field and the care in a thoughtful and evidence-supported way. And when I say evidence, I'm not necessarily implying the need for randomized placebo-controlled trials with, you know, there are many ways to learn. And there may be also gaps in data that I'd be curious to know, what is it that you would like to know that you don't and have difficulty because the data are not available. So, you know, I think I look forward from learning. I look forward to learning from you all. And I'm just so pleased with how thoughtful you all are in looking at different aspects of the problem and still at the forefront, you know, laser focused on providing the best care to the people who we serve. So thank you.
That's great. Thank you, Shari. We have a question from the audience, and the question is around the reintegration of somatic and behavioral health. Some of the themes we've heard from our panelists speak to the COVID potentially being an opportunity to accelerate many innovations that have just taken so long, including telehealth, but non-innovations as well, like getting just parity in general for behavioral health services. Somatic and behavioral health integration has been talked about for a long time, and it seems like it's starting to happen. Corey, maybe I can ask you, have you seen an acceleration of the reintegration of somatic and behavioral health? And since we only have about 4 minutes, if we could have like a 45-second answer so we can hit another question.
I saw momentum, but I think COVID's gonna crush that momentum because there were a lot of things out there at FQHCs that were looking at the integration, which probably led that effort overall. But there were a lot of partnerships that were being formed between typically non-partnering people, standard hospital systems with provider bases, and then outpatient behavioral health looking to come into that. But because the massive financial hit that these systems are going to take, they're now not looking at capitalizing these systems to be fully developed. And on the back end of that, the vast majority of integration that was occurring, at least at the county level, was paid for by county government programs, which are now going to be fully nixed. I mean, like if you look at the behavioral health and addiction treatment integration at the California Department of Corrections, the largest prison system in the country, I'm in charge of a project putting addiction treatment in there right now. And their new budget, just because of what's currently happening with COVID, just got cut by, you know, they took 50 billion off the top. I mean, it's not small numbers. So now that integration and smooth access for somebody to walk out into an integrated program just is gone. And without support, this is going to happen in every community because we were just starting to get hospitals to lean into this, but they're being crushed. And as a practicing emergency medicine doctor, I will tell you, when I work my shift on Sunday, I'm twiddling my thumbs, and all I'm seeing is COVID and super sick people who don't have COVID. And that's just a reality of every other hospital. Even if COVID doesn't exist in their space, they're getting crushed. And I think that's going to stop it.
That's very helpful. So we have a minute and a half left, and I'm going to put all of us on the spot, and I'll volunteer myself first. Let's think of 5 parting words that we want to leave the audience with that pertain to the future state of the prevention, treatment, and recovery system. So I'm gonna think on the spot here. I'll go first, and then I'll just go kind of in Brady Bunch order, whoever's top left. My 5 words are how to accelerate value-based payment. Sorry, 7. So those are my 5. Corey, what would be your 5 or up to 10 words that you want to leave as a parting remark?
We cannot be risk averse.
Ooh, I love it. Okay, Kelly.
Go to ASAM website. That's ASAM, American Society of Addiction Medicine.
Beautiful.
And I also have to say that we're having a COVID addiction webinar with the National Academy of Medicine and ASAM tomorrow to get at some of your COVID questions. And we're doing another one in 2 weeks. I think the one in 2 weeks, Dr. Waller will be on. So
beautiful. We'll count that as an extended 5 words. Kate.
I'm going to say COVID is going to create a mental health need that is unprecedented. I don't know how many words that is, but
That's
more than 5.
Thank you, Kate. Shari Dubester.
COVID-19 as opportunity to reinvent.
Oh, great. And Shari Ling.
Yes. Solve to the patient's needs.
Woo! Way to end it on a perfect note. We are finished right on time. Liz, I think we can hand it back over to you. And if you don't take it over, we're going to just keep talking.
No, I'm here.
Okay, thank you, everyone.
All are tired, especially Kelly, who's practically on payroll for us. We'll see you tomorrow.
I'm going to get paid?
I know, Victor's not on right now. But no, you get the Volunteer of the Month award, that's for sure. All right, thank you all. This is a tremendous session. We appreciate all of the panelists for hanging in there towards the end, as well as our webinar participants. So again, thank you all for your terrific presentations and discussion. So I'd like to conclude the symposium by extending our special thanks to all of our speakers and to all of the webinar attendees for participating and taking the time to join us today. Today's speakers have touched upon a wealth of topics and opportunities to stem the addiction crisis while simultaneously strengthening the health system and improving outcomes for patients and families. We also heard our speakers touch on the convergence of the opioid crisis and the COVID-19 pandemic. COVID has certainly put an enormous strain on individuals, families, our health system, the economy, and society more broadly. However, as we've heard today, despite the weaknesses the pandemic has revealed, it has also demonstrated our capacity to rapidly innovate in times of urgency. So as we emerge from the pandemic, it will be important to reflect on not just the gaps it revealed, but also the important lessons learned, what worked and what did not in providing continuity of care and care delivery, in maintaining social connection, in reaching those who are most disadvantaged or disconnected, and across changes that were made to regulations, policy, and practice. Both before and in the aftermath of the pandemic, I want to underscore that the NAM's Action Collaborative on Countering the U.S. Opioid Epidemic remains committed to highlighting the most promising and evidence-based and actionable opportunities to support the health and well-being of individuals with substance use disorders and chronic pain. And we hope that you'll continue to follow our important work as we go forward. So again, thank you for your participation today. And as a reminder, this webinar has been recorded, and in the coming days, you will be able to view the webinar recording as well as the speaker slides at nam.edu/opioid collaborative. And if we go to the next slide, like Kelly, I do want to do another plug for an upcoming webinar. If you want more, there's more to be had. We have a webinar tomorrow at 2:30 p.m. Eastern in collaboration with ASAM, focused on treating addiction across the care continuum during COVID-19, challenges and promising practices. We have a terrific set of panelists lined up, so we hope that you'll join us again for that session tomorrow. And in the interim, please stay safe and well and enjoy the rest of your day. Thank you all for being with us.